Okay, welcome. So today, we're going to do things a little bit differently. First, I'd like to welcome you all to the International IVF Initiative. We have a number of panelists here, and they're going to join us for an in-depth discussion on the pros and cons of using oil overlays for embryo culture. And co-hosting this will be my esteemed colleague, Liesl Nel-Themaat. Did I get it right?
You got it right. Very good.
Actually, I'm just kidding. That's not at all what's happening. Today, the Mavericks are going to take this thing over. And
Whoa, Gerry, I have to interject here. Now, we may be taking it over. Yesterday, during our rehearsal, Giles was very, very serious, telling us that we have to keep to the script and doing things a certain way. You know, they've been doing it for a year and a half. Well, Giles, when's the last time you asked the Maverick to do anything the way you want it? So, hold on to your horses, your chairs, your wings, because this session might get wild. Gerry?
Okay. Giles, if you could go ahead and roll the slideshow. So the first thing we're going to do is we're going to address kind of the big question. Who are the Mavericks? Certainly we have Mavericks involved and they know who they are. But there are a lot of people who either haven't heard of us or have heard of us and don't really know who we are. So who are the Mavericks? Well, it's kind of a long story. But basically, the Mavericks are a disorganized group of uncivilized reproductive biologists who cause trouble in a private Facebook group and wherever else they happen to gather, which definitely does not happen in random bars at random international conferences. The backstory to the whole Mavericks movement here. That about 6 years ago, Stan Harris and I decided that online interactions managed by our membership organization, I'm not going to name any particular online forums, but they didn't really encourage people to interact. Having a nanny tell you what you could or couldn't say, who you could talk to, that sort of thing, that got a little stale. And it was tiresome watching young members of our industry ask questions only to get pummeled by some self-righteous know-it-all. And I'm not at all referring to you, Dr. Pomeroy. The Mavericks Facebook group was created basically to mimic the atmosphere in a hotel bar at a major conference, right? So it's a place where a lot of people from everywhere gather. Creativity kind of flourishes. People build connections. They debate science. Sometimes they're ridiculous. But generally, everyone has a say and there's no hierarchy. So it's designed really to cut down on social barriers. So we've grown from a few dozen or so on the first day to over 1,100 members at last count. Our members span the globe, as you can see in the initial feed. Our only rules are to be nice to everyone, leave the corporate sales pitch at home, and try not to cause too much trouble. Any member can add a member. Everyone should be a reproductive biologist or a closely related field, so we don't really want your family members in there. And that's about it. So from there, we're going to get on with the show. So today, we have a group of panelists who you may or may not know. And they're going to be debating some interesting topics, both prepared and submitted by the audience. This is designed to just kind of flow organically. So we're going to see what happens. But first, I'd like to take a moment to introduce my co-moderator, Liesl. For those of you who don't know her, Liesl was named after a character in The Sound of Music. Her last name is awkward to pronounce and even more awkward to spell. And she's also the lab director of Shady Grove Fertility, Colorado. If you do know her, she will tell you that she was a protege of the esteemed Bob Godke from LSU, and she's South African, and that makes her better than you. Every time you see her, she will tell you these things again and again and again. Liesl?
Well, thank you so much, Gerry. I appreciate that. Actually, I was super excited about this session. I always wanted to do one of these with you. Because speaking from experience, the stuff we get to do at conferences, it can only be good to be on stage together or on screen together. But just a few words about Gerry. You know, of course, he's amazing. His full bio can be found online. It's on the website. But in addition to being just an awesome advocate for lab staff on every single leadership board, he's probably the president of every single board any one of us can be on, and he might be the president of the country and the world one day if he keeps this trend. But in addition to that, he's also the associate professor and clinical lab director for the reproductive endocrinology and infertility division of Virginia Commonwealth University in Richmond. But hands down, what he will be remembered for most when he flies off into the sunset one day, apart of course from his iconic dance moves, is for starting Mavericks. The impact that this group has had on all lab professionals around the world is truly remarkable. I commend you for that. And I personally want to thank you for that milestone, because at least 5 times a week, I have a question that I need to know what other people are thinking, and I post it, and within an hour, you have at least 20, 30 answers. It is immensely valuable. So congratulations and thank you. And so with that, I'm handing it back over to you.
Thank you very much, Liesl. I appreciate that. I think you've swelled my ego quite enough. And you know, I still remember you ridiculing my dancing, so we're all good there. Okay, so I'd like to start off by introducing our panelists. I apologize if I make a disaster of anyone's name. We practiced this in advance, and I'm still probably going to screw up at least 1 or 2. So first, Dr. Mara Simopoulou.
Can everyone switch on your videos?
Yes. Okay. Dr. Simopoulou comes to us from Athens and is here to definitively illustrate how much more refined the Europeans are than the rest of us. She's an associate professor of physiology and embryology, personally invested in medical education, research, and forming and testing the right hypotheses with her team. You don't want to know what happens when you test the wrong hypothesis with your team. Next up, we have Ashley Wong. Ashley Wong has been a clinical embryologist since 1999, and it's rumored that her motivation for pursuing a career is a deep desire to clone the MVPs from the last 30 Stanley Cup games so she can form her own team. Then we have Dr. Betsy Cairo. Betsy's a board-certified reproductive biologist and owner and founder of Cryogram Colorado, the only commercial cryobank in Colorado. Coincidentally, marijuana use, which is legal in Colorado, has been tied to decreased semen quality, a fact that has nothing to do with the success of her company. Next up, we have Huey Huynh. Huey created the first 3-legged chicken embryo while pursuing his degree at Temple University. He was trying to negotiate a deal with Colonel Sanders, but sadly the chicken was too fast and no one knows what it tasted like. So, racked with depression, he spent the next 10 years at Lehigh Valley Reproductive Endocrinology and Fertility Center as a senior embryologist and lab supervisor before moving on to the private sector with Life Air. Huey is best known for covering everything he owns in sperm. Don't ask.
Very good, sir.
We know. Next up, Dr. Michael Baker. Michael is notable for earning the Chipotle Lifetime Achievement Award for sheer volume consumed. He majored in genetics at Texas A&M University and obtained his PhD in reproductive biology from UT Southwestern Medical Center. Currently serves as clinical laboratory director at Aspire San Antonio, as well as offsite at Aspire Dallas and Denver Fertility. Michael is also known to brag about driving the rings of Kerry, although I understand Kerry's husband takes issue with this. Next up, Salu Ribeiro. Salu is a true Renaissance man, and I'm not even joking here. He's a senior embryologist at UCSF with experience in numerous other public and private labs. I could literally spend an hour talking about his various side projects he's discussed with me over the years. He's ridiculously successful. So much so that Elon Musk occasionally asked him for business advice. We have him here hoping that some of his intuition will in fact rub off on us. Seriously, get him aside sometime. It'll floor you. You'll feel really, really bad about yourself. Next up, Dr. Bryan Kloos. Bryan Kloos is a high complexity laboratory director with over 2 decades of experience helping couples achieve pregnancy. This is kind of interesting because Bryan was in my wedding party a mere 18 years ago, and he was still a grad student at the time. So when you do the math, some of the couples out there are still probably looking for it. And finally, we have Dr. Sheela Ali. She's the scientific director at Dallas IVF. She's been in the field of human reproduction since 2008. Has had the privilege of serving as a panelist in the space biology research program with NASA and is a research consultant for ICAO, a subgroup of the United Nations. I don't actually know what that stands for. I apologize. So Sheela is really far too distinguished for me to ridicule here. And I'm not saying that because of what happened to the last guy who ridiculed. So from what I've heard, it was completely an accident, but we'll leave it at that.
I have pretty thick skin. We'll see how it goes.
Okay. Okay, back over to you, Liesl.
All right, thank you, Gerry. That was quite the introduction. So just to remind everyone before we start, remember to ask your questions in the Q&A section, and the questions will be triaged to our triage document, and we'll try to get enough time to get to all of it. So let's jump in. So the first topic we're going to discuss is one of the things that labs do differently, and specifically, what does your lab do with 0 PN and 1 PNs? And I may even throw in 3 PNs at this point. So all panelists, the floor is yours. I will just point to Bryan. You can start.
Right, speak up.
All right, so 0 PNs, 1 PNs, 3 PNs, abnormal fertilization. In my laboratory, the protocol is in absence of PGT, that those are abnormally fertilized gametes and they are not cultured through and are ultimately discarded.
Just, I was gonna say, what about if you have only 0 PNs? Do you attempt rescue ICSI, or would you culture them out to see if maybe they fertilized and you didn't catch it?
So we're predominantly an ICSI all laboratory, at least at Park Ave, and we don't employ rescue ICSI. If we did have a situation where there was complete FERT failure, we would watch the embryos for an additional 24 hours to see if we have any cleavage. But you know, under normal circumstances, in absence of complete fertilization failure, we would discard based on abnormal fertilization.
Okay. Ashley?
Well, we are not primarily a PGT lab, which is interesting. And we are not an ICSI all lab. So we would attempt rescue ICSI in a conventionally fertilized situation, depending on the number that fertilized. You know, usually it is a total fertilization failure where we would implement that. But I do see all kinds of stuff, especially with EmbryoScope and some of the labs that I visit. You know, you're just continuing to monitor a single system. But in our lab, we would keep a 1 PN if it was fertilized via ICSI. And we do a 24-hour check, or even a PNBD check, as we would call it, in some of the labs that I've worked in. It just kind of depends on the system, the management, the incubation area, or type, and what type of fertilization was used. I wouldn't rescue ICSI an already ICSI'd egg.
Michael Baker, you look like
yes. So I am in predominantly ICSI laboratories with a high frequency of PGT ordered by our physicians. I have worked with the EmbryoScopes, and I have really enjoyed being able to rewind and fast forward to observe PN formation. But in the absence of the time-lapse incubator technology, we are keeping the 0 PNs and the 1 PNs to see if they develop into blastocysts. They rarely ever do. We are very disciplined in our timing of our FERT checks. We are aiming for that 16 to 18 hour post ICSI FERT check. So I'd say it's only once in a blue moon, but we do hold those just in case there's an early or late fertilization event observed or not observed. And 3 PNs we discard immediately.
So I would like to interject on your 3 PNs there. Is there anybody that, since there are, I believe, 2 PGT platforms that can distinguish all types of triploidy, do any of you keep your 3 PNs and will send them for PGT and transfer if it's euploid?
We do not.
Oh.
Nope.
May I ask why?
But you know what? There is the group that holds on to the 1 PN, same question to that group. Do you use, if that 1 PN develops into a high quality blastocyst, do you then use those PGT platforms to understand if it's truly, if it is euploid, to make sure that it's not from it's not a uniparental disomy case? We don't hold on to 1 PNs.
I think, you know, all of this information we're using to filter for selection criteria. So, you know, you're always categorizing embryos and separating them and processing the information gathered about each one, right? So if you had a 2 PN embryo that developed into a high quality blastocyst, or a 1 PN embryo that would develop into a high quality blastocyst, you would of course transfer the 2 PN derived embryo. So I think, you know, it's the same with those 3 PNs and discarding them. If you're going to use that information for selection criteria, unless you had a case, and we had one mentioned on Maverick not too long ago, where there was a high number of 3 PN, I wouldn't necessarily look for that paternal or maternal source unless I was gathering information that could change that patient outcome in the future. If there were other embryos available, I'd select them.
Ashley, I absolutely agree with you. It's a matter of, is it a luxury or not? How many embryos are there available? And also the information that we get from the number of color bodies is really, really important to guide with regards to what you're going to do. You know, do you have a 3 PN with a single color body, or do you have a 3 PN with 2 color bodies? It's a completely different story. So I think that's really important. And I have to say, I agree with you guys with regards to 3 PN, you know. But the 1 PNs, especially, you don't have anything else, and you do keep them and you see how they progress. With regards to 0 PNs, there is data out there that supports that if they do develop to blastocyst stage, does that mean that we've missed the window to check for, you know, is that a product of early, you know, fusion, and could that even be a good thing at times? I don't think it's a good thing if you only have, you know, 0 PNs, but I'm just saying we need to consider everything, and it all depends on how many embryos are there available and what you can do with what you have, and, you know, the couple that is opposite you, and at what sort of you know, part of their journey are they at? Is it their first attempt? Is it their last attempt? You know, you have to put everything together, and just IVF is, you know, custom made, sur mesure. So we have to take everything into account, especially if PGTA is not part of the equation, even more so.
So Dr. Kim Pomeroy popped up and said there's really 2 types of 0 PN. What about those that cleave? I think that's kind of where we're running with this.
Yeah, one thing that we learned at our clinic after with the time-lapse system, we're able to detect so those PNs that disappear very quickly compared to, so we, before time-lapse, we just did a regular FERTA between 18 to 20 hours, 16 to 20 hours, but now we changed the approach that we put everything in a time-lapse incubator, and then we can catch some of those things that the PN that disappear quickly, and or some that there are 2 PN at certain time, and then now we can see an extra PN at extra hour that really help us to kind of put that embryo aside and not transfer that and transfer the true 2 PNs based on the time-lapse incubator, which we understand not everyone has that technology just yet, but that really helped us. One, arriving earlier in the lab because we want to catch those PNs with the system, but with the IVF micro drop, you still can put all in incubator, wait a few hours, and then reassess your embryos.
I think there's a lot to be said for the type of platform that you use. We have, since the platform became available, the first one, we would, depending, you know, if the patient only has 1 embryo or 2 embryo, whether it's a 0, 1, or a 3 PN, we will biopsy it and send it for testing, and you do get some euploids, and there are reports of transfers with live births, normal live births from 3 PN embryos. So I think it really depends on what technology you have available to test your embryos with.
And I think, you know, the other thing is you look at devices like InvoCell, right? all you know is what you come up with at the end a lot of times with an in vivo cell, right? I mean, just by the nature of how the device is used. So when we look at that and we start looking at the success rates with it, and I actually don't use in vivo cell. I've worked with a few clinics that have over the years, but you know, they are seeing pretty good success with it, and it makes you wonder, you know, are we just completely selecting for the best embryo, and anything that's not a perfect 2PN isn't the best embryo? I've seen some beautiful looking 1PN blastocysts. We send them off to biopsy, and sometimes they're normal and sometimes they're not. More often they're not, but it is an interesting question. So moving on from there, kind of the same vein, day 7 culture. Where do you guys stand on day 7 culture? I got into this, there was no, I mean, day 7 was kind of an extreme, and now it seems to be more and more common. But what are your thoughts on embryos that take to day 7 to develop?
I would start on this because that's something that I learned at least at our clinic and others. Depending on your retrieval time, especially with the donors, if you're doing a retrieval at 4 p.m., is that your true day 7 or just a late day 6? So that's something that we start pushing. And then some clinics that I know they're doing as a standard of care, day 7. And some of them, they're just changing the method of grading as on days 5, for example, they will not freeze any C embryos, but on day 6 and 7, they'll freeze C embryos. So that way the day 7 is still some of the benefit.
Do you count them down if they take that long to develop? Or do you
no, well, there's still like the transfer criteria is day 5 first, day 6, and day 7 last. But at least as Dr. Simopoulou said, it's and Dr. Wong, Ashley mentioned, it's the customized IVF. So depending which clinic you are, you're catering to that population that they might choose your clinic because you're doing day 7 compared to another clinic that will only do day 6.
You know, it's hard to say that there's one answer to any question here because, you know, one of the things that one of our Mavericks said in one of the past meetings is that there are many right ways of doing IVF. And I do believe that because it depends on your center, it depends on your situation, your patient population, and your specific demographics. So with all of that in mind, and then also our responsibilities as leaders in the field is to make sure that we have very clear protocols, and so that our staffing understands exactly what it is that our expectations are and what we can do, keeping in mind that where our patients are, they come first, and we're doing everything in our power to make sure that their cycles are successful. So with that, we can expand some of the protocols to allow for a little wiggle room on the ends there. So when it comes to the day 7 question, at our lab, what we do is we count the number of hours because just like you said, so it could be a later retrieval, like our retrieval start at 7:30 in the morning, and then our last one could be closer to noon. So we'll just count the number of hours post-insemination. And so our cutoff is 140. And so 140 hours post-insemination would be probably pushing it when it comes to judging those embryos for development and making sure that they are developing appropriately. We compare them to day 5 as far as cell numbers, and then expansion, and of course, you know, grading criteria for both ICM and TROPH. And I find that suffices when it comes to getting all of the embryos that are going to be potential candidates for implantation and or freeze. We don't push out to day 7. We just didn't see a benefit in the past when we've attempted to do that. The pregnancy outcome suffers, and then so does recovery at thaw.
Do you do a lot of PGT?
About 90%.
Okay, interesting. We actually found ourselves pushing a little further out because of the PGT issue. So we're waiting for a good solid herniation, which tends to take most of our embryos a little bit longer than when we weren't doing PGT.
We started doing day 7 transfers, I think about 2 years ago. And honestly, the reason was another Mav that's from the Bay Area, that's, you guys will probably all know. He just said he doesn't want to get sued because he discards day 7 embryos, and then the clinic next door has a baby from day 7, and then the patient is friends with the other patient, and you discarded my day 7 embryo and it could have made a baby. So that is really why we started doing it is just for legal liability reasons.
So why
And
not
we did read
AA?
quite a few of them.
I
Say again?
think sorry, was someone else talking?
No, you go ahead.
I think I think we need to be really careful with the day 7. It's opening up a new direction in things, and like you say, what we offer to the patient. And I completely understand. Is the perfect example that you brought up. What happened with a patient that was friends with another patient, and she got pregnant and was with a day 7 transfer, and why doesn't your clinic offer that? And definitely, if we keep embryos to day 7 overall, the exact number is going to be more pregnancies at some point. But at which point will we be able to say that? And I don't know, just looking at the data, and there are a lot of retrospective studies. There's still a lot of work to be done on that. But I completely agree that we need to make room for, we need to be able to wiggle around but I'm not sure with regards to just everything to be pushed to day 7 and whether that should be a routine clinical practice. I'm still not sure about that.
I agree with that. I don't believe day 7 as a standard protocol is appropriate. Certainly not for all clinics. Maybe there's a small group of clinicians that might fit depending on the patient demographics, but I certainly wouldn't change my protocols based off of the clinic next door. I believe that you have to rely on your consents to do some of that work for you, and then refer your patients back to your consents that these are our standard protocols and this is what we include in our care. And if you accept these standard protocols, and if you agree with that, then we can go ahead and move forward. It's a partnership between you and the patient. And so each party must honor that agreement.
I think it would be interesting also to ask the question, what percentage of embryos are blasts at day 5, day 6, and day 7? The labs that are having success with day 7 culture, do they have fewer blasts on day 5? Is it possible that maybe the culture system is lagging a bit, and that the embryos aren't meeting their normal developmental cues on specific times because maybe, I don't want to say suboptimal culture, but another a slew of factors. But I think it's important to really look at everything from all angles, and obviously we want to do what's best for the patients, but we need to have appropriate consents and protocols in place that allow us to do these culture systems.
So I have a question.
Sorry,
I have a
go ahead.
Go ahead,
So,
Betsy.
okay. At what point, because we don't do embryology and I have a cryobank and patients own their tissue, it's their tissue. And so what I'm hearing is that at what point does a patient have a say in the outcome of their embryos? Because in our setting, it's their tissue. And I know we may want to think that we are protecting people from themselves, but it's a very highly emotionally charged environment. And we all know if this went to jury trial and all of those things, emotion is going to play into that. And so my question is making decisions for patients because we feel they're uninformed, but yet we're informing them every step of the way of day 3, day 6, what are their embryos doing? And as like Liesl said, they talk to each other. And I'm just curious as to how you view this tissue in the lab as yours, as theirs. Whose is it, and who gets to decide?
I think that's an interesting question, but as we know, there's unhealthy tissue, cancerous tumors and other things are that patients as well, but they entrust our care to take care of them and that tissue. And if we allow patients to dictate the protocols we put in place, how does the laboratory director, who is legally responsible for the staffing and the events that happen in that lab, have any control? So I think you have to be really careful. In our country, in the United States right now, we operate under certain mandates that say we have to have protocols, they have to be followed. And it isn't a patient-to-patient system that's determined. It is a consistent quality of care that is determined by that laboratory director. So I would find it really challenging if patients were able to call on a case-by-case basis and determine how their tissue was handled.
And to add to that, Ashley, if we deviate from our protocol to accommodate one patient, that might open up a further issue for the laboratory. Other patients might call in and say, well, how come she was given a different treatment than I was? So that could create just liability across our entire patient database. So we absolutely would not be open to doing that. Of course, any extreme circumstances we'll take into consideration, but just as a general norm, we certainly wouldn't treat one patient differently than another patient.
And I think too, as a patient, you have the ability to enroll in care in different providers. So if you want to have a new patient appointment and interview that provider on their, basic systems or, methodology, you're more than able to choose different clinics that will accommodate the type of care or family building that you want to do.
Okay,
All right, so I want
hang
to.
hang on, just before you do that, Liesl.
Okay.
So we have a couple questions. I know what you're going to do. So before we do that, so a couple comments in our kind of rolling comment section here. So one individual asked, fresh ET on day 6 or 7 versus frozen. I think universally we're probably talking about frozen day 7 for those of us who cultured a day 7. I definitely wouldn't transfer a fresh day 7, and for the rest of you, I think we're in agreement.
That's right.
Just kind of to clear that up, he asked that we please comment on that. The other question though, and this is something I've seen, but have you guys noticed different developmental rates with different media? And how does that affect your day 5, 6, or 7 culture length decisions? And I know I found some medias actually I get really rapid growth, but the embryos seem to burn out. I kind of have a favorite media and favorite conditions that give me sort of middle of the road growth, and I get the largest number of blasts and the best pregnancy rates. Have you guys looked at that, and what are your thoughts there? And then we'll let Liesl jump on after everyone gets quick commented.
Yeah, so using some different media brands in different areas of the country, I have seen some different developmental rates. And I very well might be the clinic next door that Liesl's been talking about, because a couple of years ago, I did start saving embryos till day 7 in order to, the laboratory just had very few day 5 blasts, and we were waiting for a certain size for our PGT biopsy. And the day 7's blasts looked beautiful on occasion, and certainly felt a moral obligation to give those embryos a chance. And we have live births from day 7 embryos, though we do, I have our physicians counseling the patients on the expectations of those day 7 embryos. They are perhaps half of the potential of a day 5 or day 6 blastocyst. But then moving around the country again to a different media, and we have much more day 5 embryos, and perhaps day 7 culture isn't necessary in my newest laboratories. So that's my 2 cents.
Michael, so
I'm so sorry, Michael, do you think that has anything to do with your particular incubation conditions that might favor a certain type of media versus the other, versus the 2 medias being one suboptimal and one, more or a higher?
I've done some thorough media splits in that particular lab and didn't see any faster blast development. So I've tried to troubleshoot, and perhaps I didn't find the right variable, but it was in multiple medias.
Just for curiosity, did you do pH checks and osmo checks?
Yes.
Okay.
I think also to remember, within your own lab, everything else the same. Some patients just go faster than others do. I'm sure you have all seen it. So I can have two patients that are inseminated within 30 minutes of each other. One will not make a single blast until day 6.5, and the other one may be full blast, all of them on day 5. So, you know, there's definitely some inherent patient potentials as well. But what I want to do now is, because we have some very passionate comments here from the audience, and I'm going to actually jump the gun a little bit and pull in a very esteemed, very well-known contributor to I3, Kim Pomeroy. You are being flown in as a guest. Thomas, if you can please put him in. But the question that he had, and it was half question, half comment, he says, not culturing to day 7 because pregnancy rates suffer, question mark. So is this protection of clinic stats, question mark? If we ask a patient a day 7 embryo only has 15% chance of implantation, don't you think a patient will be angry if you discarded their 15% chance, which is far better than 0 if you toss it? So Kim, if you would switch on your video, we would love to see you and hear your voice.
This is how us Mavericks are.
There we go.
I just worry about that there are many clinics that have old protocols and they haven't taken the time to review them when new technologies have come out. If someone, for example, would transfer, say, a 1PN embryo, is there evidence, a true 1PN, that it would produce a baby that would be viable, or a 3PN, or even a day 7? If you transfer a day 7 embryo, if that pregnancy rate is only 10%, well, what if you went to the patient and said, you know what, we're not going to transfer this one embryo. Its pregnancy rate is only going to be about 10%. I guarantee you they're going to be upset. And so I think we have to review all of our protocols, because at one time it was recommended we only transfer BB embryos. And that came out at the very beginning. And some people still have that. When I work internationally, it really makes me upset when I see people that refuse to transfer day 7 embryos or refuse to transfer poor blastocysts, especially if that poor blastocyst comes from a donor source, a donor egg. So there.
Gerry?
No, I have no comment. I know that Kim will just pummel me if I, but generally speaking, I tend to be in agreement. I mean, I think that, you know, as the times have changed, we need to adapt and we need to follow the data. I mean, things should be evidence driven. And I think that's, you know, we get set in our protocols and sometimes, you know, the moves we make are not evidence driven.
Take a look at Dean Morbeck's paper, Is a C a Failing Grade? It provides a lot of evidence for transferring poor embryos and delayed embryos. We actually have very good pregnancy rates with delayed embryos in Miami, but we transfer them in an FET cycle usually.
Can we
very upset when I talk about 1PN, so.
Can we circle back to your comment, Kim, about are you following protocol or are you trying to make sure your pregnancy stats are solid? And I know I paraphrased that.
Yeah.
Well, and guys, I transfer fresh embryos, so I pick the best they have at that time. But you have a, you know, selection tool there by the freezing and thawing process. You know, some of those poor quality embryos or those day 7s aren't going to survive as well as the day 5s and day 6s. But at that point, your patient hasn't paid for a transfer at that point. You know, I'll transfer a C embryo if that's the best embryo they have. But you do have an extra layer of selection criteria with that freeze and thaw process.
Yeah, even what about embryos, let's say a blastocyst that doesn't have an inner cell mass? We tend to feel very rigid about that. How many times have you seen a day 5 embryo with no inner cell mass and you come day 6 and there's an inner cell mass?
That can happen.
You know, and like Ashley says, we need to sort these. We shouldn't probably spend as much time saying, oh, we're going to discard this. My guess is that most of us now are saving mosaics, at least some mosaics. If we're saving mosaics, we should be saving poor embryos.
Kimball, a question for you. Do you think, you know, over the past, let's say 5-10 years that our protocols are changing for legal reasons, because I think because patients are more engaged or looking at social media, and there's more legal issues as far as embryologists, what they have to deal with on a daily basis. Are we moving our protocols towards those?
I don't know whether we are or not really. I think they affect our decisions to change our protocols, but I don't think they should ever necessarily be the total basis of our decision. That's like saying, let's transfer something that's cancerous into someone just because we're afraid we'll get sued or something. We shouldn't do that, but I think it enters into it.
Mike Reed, actually, he made an interesting comment.
Things I'm sorry, Gerry.
I was going to say, Mike Reed made an interesting comment, and he said, so as lab personnel, are we making decisions for the physician, or are we only advisors to the physician and must do what he directs us to do? And that kind of comes back a little bit to, this whole decision of where we go, what we transfer, because, we're making decisions for the lab, but what has the patient actually been, consented to do? And what do they expect from us? And that's kind of an interesting question, where we stand in our relationship to the patients.
I do think though, it's shifted, maybe not for social reasons, but we were lucky when I first started to grow 8-cell embryos in the lab. We were like, woo! And then it was blastocyst formation. And the goal of a cycle was to get one baby. And that's changed very much since I've been in the field.
Okay, I'm holding a space for Mara. She's been trying to talk.
Yes, Mara.
Hi, Tim. Thanks. No,
Hey.
I was just going to say that I'm listening to you guys, and I think things in the States is slightly different than than what they are in Europe sometimes, or in Greece, which is where I'm practicing embryology right now. So I think sometimes, like you say, if you work in a smaller lab, we're not as worried about lawsuits as you guys are. That's that's one thing in the States. Things are a bit more heated. So if, for example, with regards to the day 7 situation, I think if you're running a small IVF lab and it's as Gerry said, it's a matter of how you make decisions and who makes the final decision and how much do you involve your patient in the final decision. And we do try, we have a small IVF lab, so we do try to include the patient. It's a slippery slope, yes, but I think, if you provide them with the information that you have and the data that you have, and you try to include them, I always feel better when I do that. Obviously, that doesn't, not every patient needs to go through that process, but for some cases, we need to make room for that. It's important. But like I said, it's a matter of how big the lab is, does, the everyday program and schedule allow for something like this? Do the embryologists took the patients? Do the physicians only took the patients? It all depends, but I think it's especially for special cases, I think we need to make room for that, and we need to let them in, and it's good if they can make that choice, and if we can make that in a safe environment so that no one has to worry about lawsuits, that would be fantastic, so that we can go on and do our jobs the way we know best. That's what I had to say.
I agree, Mara. If your protocol says we do not transfer ever day 7 embryos, it handcuffs you. And some of those decisions were made before we were using donor eggs to make embryos. And I've seen pretty rotten looking donor egg derived embryos that result in pregnancies.
But I think we're talking about two different things here. If an embryo is already frozen, that's being shipped in from another lab, whether it be a donor embryo or an autologous embryo, if it's being shipped in from another lab and it belongs to the patient, regardless of the source of the embryo, if it's her through embryo donation versus through creation of her own, we would still accept that embryo since it's already in the frozen state and attempt a frozen embryo transfer cycle at that point. However, when it comes to our internal protocols, our protocols are, we would not culture up to day 7 or transfer, we wouldn't culture up to day 7 or freeze or biopsy day 7 embryos. So two completely separate things. So in your experience, are you noticing that the labs that are not culturing to day 7 are also not accepting already frozen embryos from day 7?
Are you talking to me, Sheela?
Yeah, I am.
Oh, I didn't even consider frozen embryos. I'm talking about fresh embryos.
Oh, I see. Because you said they wouldn't accept, labs won't accept for donor embryos that were day 7 that don't necessarily.
Oh,
look-
I'm sorry. I misspoke then. I didn't mean it that way.
Oh, I see. Okay.
I just meant they wouldn't allow the freezing of day 7 embryos in their lab.
I see.
If you
Okay.
have that as a fixed thing, you have no latitude and you're actually handcuffed. I agree correctly so that you could have maybe legal issues with it. But on the other hand, if you're doing something that is the opposite of what standard care or what everyone else is doing, that also leaves you that same probability of facing a suit.
I think a lot of people are probably hesitant to do day 7 freezing, also because of staffing limitations. Dr. Simopoulou mentioned that she touched upon it's almost 50% more blast checks, and it's as high as 50% more freeze procedures. And in a large enough lab, that could require another full-time employee. So it really is just a matter of how much care can we provide patients.
So Michael, I agree with you on this, but just to say that the compromise between the physician group and the lab group, where I've seen some clinics is just having a compromise in between. So by day 6, if you don't have 10% of blasts, then you culture to day 7. Otherwise, you don't do day 7. So there's a middle ground where there's a chance that you can give to the person. At least they will have some blast to be transferred or frozen, and that compromise about 10% in some labs that I've seen.
Okay, so I'm going to interrupt here because we've been beating this topic for quite a while. We're going to switch gear a little bit. We've been talking about embryos. Let's talk about sperm, right? So sperm, we've been doing the same thing for 40 plus years, processing, semen analysis. If anything, we're doing less now. There are new devices out, Zymote, of course, being probably one of the most representative. There are other microfluidic devices out there. What do you guys think the future is for the andrology side of things? Do you think there need to be changes that we're not instituting? Are you instituting changes? What would you like to see? Have at it. Oh, and just to interject, yes, Liesl is Goose in this particular setting. Okay, sperm people.
I would say one thing that we start seeing more nowadays is the sperm nucleation, so we can see the DNA fragmentation. So that DNA fragmentation has been a big push from the physician groups that I've seen to understand if that can assess if a person is having failed pregnancy or SABs. But it's still a very new technology, I think. I mean, not new, but used new in the diagnostic arena for IVF labs that I believe we were not there yet. And there's more things that we all know that sperm can contribute for a good blast. I've seen cases where used to split, having same donor with 2 different sperm sources when we had shared cycles. And you can see that the sperm has a huge impact, even though both of them was normal morphology. But one side, group A, was beautiful blasts and group B, poor embryos, but the sperm analysis was almost identical. So whatever that information that we don't know yet, there's still more to investigate. But I think sperm has, andrology has been forgotten a bit because of ICSI, that contributed to not the evolution of that field.
I think one of the more recent changes in the freezing techniques is freeze media without the test yolk buffer versus one with test yolk buffer. And, many labs have started to move away from the freeze medium with test yolk buffer. We did, some comparison studies here as far as recovery post thaw. And I mean, it was so difficult to make a decision to completely move over to the test yolk buffer free medium when it comes to cryoprotecting, because we've noticed that there is a patient-specific factor that's involved. There are some patients' sperm just recover better regardless of the cryoprotectant use, and others show more impact from the cryoprotectant. So I'm not sure that there is a there has been a product introduced into the market that really makes such a difference for recovery, where we see an improved recovery across all patients. So I know that that's our take on it here. We haven't come across haven't come across a cryoprotectant that has shown that improvement, but that would be the next thing that I'd like to see is, development and research that goes into sperm cryoprotectants that truly do improve not only post-thaw motility, but also we'll look into DNA fragmentation pre and post thaw to see that if there's any improvement there or impact from sperm cryoprotectants from that point. And then also salute for just to add to some of the comments that you just made. DNA fragmentation, when it was new into the field, everyone just seemed to hop on and wanted to order these fragmentation analyses test. But at the time when I investigated further into the test and how to really help patients understand what the results are. So when the results are in the abnormal range, well, what do we do as clinicians and as laboratorians? Based on the information that I gathered at the time was, well, you do ICSI. If the DNA fragmentation content is high and the sperm analysis are abnormal, then you'll just go ahead and do ICSI. Well, what about all those programs that are all ICSI anyways? We're about 60% ICSI here. And if we're doing ICSI anyways, how does that information help us as far as making decisions for the patient? So due to that reason, we discontinued referring to that test for our patients. But again, that test is it's not fruitful in that way. It doesn't help us try something different or make a decision for the treatment outcome or the treatments for that patient to possibly add to the success rates. So where I would like to see the field go is one, an improved cryoprotectant media, and then two, possibly a diagnostic test that can give us more information on sperm that might help us with treatment options when it comes to IVF. Perhaps ICSI is not the answer for everyone.
Right. And including also the new technology that can choose is PIXI. So if frag doesn't work, the only option is ICSI. Oh, let's just add a PIXI, but would the PIXI really help this population or this specific patient? And then the type of freezing media, not media, but the technique that you're using is slow freezing or vitrification. I know what most of us are using slow freezing, but would vitrification be the solution for sperm freeze?
I think we have still a long way to go with regards to how we handle sperm, and the way we decide how we're going to treat sperm has to do with how the lab works. And if we're talking about doing mostly ICSI, then as Dr. Sally said, then how is that going to help? How is that going to make it any different? We try to do as much IVF as possible in our lab. And I think the next few years are definitely going to show more with regards to sperm and directions in research, and we need to know more about sperm. We don't know as much, and it's all because of ICSI, because ICSI came to our hands and then we just went for it, and maybe I think we just went for it too far. So definitely, I completely agree with regard to cryopreservation. We need better media. It can't be that everything in tissue culture in the world is progressing so fast in other disciplines, and we're just stuck with the cryoprotectants that we've been using in the same kind of compositions that we've been using the last. I don't know. We need something more, and I think that's coming up because there is a direction in research on sperm. So I think we'll see more in the years to come, and hopefully sooner than that. But it's doing ICSI or not ICSI, it just makes the difference in the IVF lab and the way that you're treating sperm and thinking of how. No, that's what I think.
Have you seen cases where the person had or the patient had poor blasts, and now they want to do surgical sperm aspiration to increase the blast relation, which I have seen providers doing this, which is you're creating a surgery, which is like how far can you go? Now you're putting your patient into an elective surgery, knowing that they can't produce through ejaculation, but now you want to do a surgical procedure to do aspiration because there's a belief that there's a better blast relation. Would that be appropriate? Or have you all seen it?
We have, I feel that, well, in my opinion, let's just start that way. In my opinion, I've seen that the physicians that offer that to patients may not have had a full review of literature. I have not seen that that procedure truly indicates that there is success in blastocyst development. I think they're at this point just really trying for the patient, and that's one extra thing that they know how to do. So we don't practice that here at our center, especially when a man can ejaculate and have sperm in the ejaculation.
And I just have one comment too. We recently added a few years ago a QA measure for viability upon thaw. So if you're, tracking that per tech and long-term with decent numbers, we did side-by-sides with 2 different cryoprotectants and looked at the viability post-thaw of our post-thaw samples. And, we have a standard that we want to maintain. We do oncology patients and long-term, long-term storage patients. So we obligate ourselves to commit to providing quality care and continuing to measure that and have standards for that. So I suggest, all labs that are doing cryopreservation should have some sort of quality measure for that and continued strive for improvement.
So Michael Reed from the audience is asking a question specifically for Betsy. He says, what buffer do you prefer to use for your sperm donors and client depositors? Egg yolk, glycerol, only base? You probably freeze more sperm than any of us. So you really should take the floor here.
Oh, Michael, wait, I see that bus coming. So, yeah, we are old school. We use sodium citrate egg yolk buffer at a 20% concentration, and then we do a 1 to 1/2 extension. So we end up somewhere between 7 and 11% in our glycerol. I can tell you that I've been doing this for over 30 years. I have seen probably in that time frame maybe 5 patients who just didn't freeze. I can only attest it to possibly a glycerol intolerance. I did everything playing with the concentration. Some people just don't freeze. I feel, and again, I'm biased, but we get a really good harvest, a good post-thaw, because everything we do is pre-washed, and we just feel that that is better, takes out a lot of the toxins of the seminal fluid that we feel, obviously, and everybody knows is not conducive to sperm survivability, but is only really necessary for sperm transport initially into the female tract. So look, thinking about that, the other thing I'm hearing when I'm hearing everybody speak, ICSI did put andrology definitely on the back burner. A lot of andrology is not taught in schools, basic things, skills that I see if I'm taking on an intern or I'm training a new hire, that this just isn't taught. But the other thing that I think it's really important to know that over the period of time, we do and have and are seeing a decline in male fertility and sperm quality. And in my day, when we would get a donor and they'd have 100 to 150 million with 80 to 90% motility, really clean, really consistent. And that is a very large, that's rare. We don't see that anymore, even in our sperm donor population. I don't know if it's environmental, if it's genetic, if it's all of those factors, if it's epigenetics, it can be all of those things. But what we have to keep in mind in my frame, and what I think what Michael's getting at, is that because male fertility is on the decline, and because we're seeing a little bit more fragility in that, we have to understand how to work with sperm and not beat it to death. I mean, it's pretty hardy stuff. You can leave it at room temperature. You can, freeze it, thaw it, does great. It's pretty simple, but you still can't abuse that privilege with it. So that's kind of where we are with it. I think all the new stuff is great, is a nice idea to look at, but sometimes you just need to have an art to your art and have a sense of what you're doing when you're processing. And these are not criticisms. These are just observations that I see people coming through my lab. And then I just want to quickly do a little segue here with respect to DNA fragmentation. Male fertility is so fragile. There's just about everything that someone with testicles does to their body, whether they ingest a Sudafed or drink alcohol or smoke a joint or do whatever, you're going to see pretty immediate DNA fragmentation on that day. So DNA fragmentation, as well as the semen analysis, is a snapshot in time of what you saw that day that began synthesis 60 to 90 days ago. And so you can talk about what you did today, but we take a history of our patients. What are they doing all the time, year round? What are we looking at? And then add 20% to what they're lying about. And so there's that everybody has a secret and they're, lying. And then of course, so I don't know, I know I kind of went off point there, but the issue is that I think when we're talking about male fertility, we definitely have to treat the person as a whole. What are they doing? The thigh bone is definitely connected to the knee bone. Everything a man does will affect his fertility pretty quickly. And then there's a long recovery time for that. And then we have these testosterone clinics popping up, and that's a whole nother discussion about horrible stuff. And then we're going to be seeing a lot of recovery on that as well. So I don't know if that really answered Michael's question, but I think hopefully it did. We do a slow freeze, and actually it's just in vapor suspension.
So just to cover a few more, I think you did, and I think to cover a few more of the questions that are coming in from the outside, again, with respect to high DFI samples, how do you recommend we prepare the sperm for ICSI, if you're going to do ICSI? Do you think TESI, I think we already answered this a little bit, but is TESI a good solution to this? Maybe PIXI? How do you think we address these things? Patients with obviously you said lifestyle, but I mean, for the rest of us dealing with a sample in real time at that point in time, for a patient with high fragmentation, what do you think?
Are you asking me?
I'm asking.
That's the panel. Okay. Well, I'll defer.
Bryan has been very quiet. Bryan, you need to speak up. You're on expensive real estate here.
I've always followed a keep it simple protocol. Single layer gradients give me ample products to work with. I can't speak with respect to fragmentation and various products because I haven't really employed them in my labs. So I'll defer to anyone else in the panel as well that might have more experience with some of the products that are better at isolating superior sperm.
Salu, you said you're working with a lot of high fragmentation samples, right? What do you do differently?
Yeah, we do. I think the fragmentation test comes to a point when the person is there's an unsuccessful pregnancy, and we're trying to figure out what's wrong with the male side, if there is nice embryos or nice eggs, younger patient, female patient, and what is happening on the other side. And then, so that's one step. And then also for our type of stem cells that we're preparing, either IVF or ICSI, how you prepare them, also there's a difference there. And for the micro drop in or IVF, I mean, that's the standard they're using to prepare that to have your 10 million minimum and try to follow the sort of WHO criteria for either deciding whether you want to use ICSI or IVF to our patient.
Do you think any of these new microfluidic devices are going to help us to pick the best sperm? Or do you just think?
I have been working on that quite a bit lately, and we're still under investigation. I think it's saves times in the lab for us. It's especially doctor's office that just does IUIs. I think that's a nice product because then you don't have to centrifuge. It's very simple to do with the type of personnel that it's employed to performing that type of task. But for it varies. I think it's a patient specific that you want to employ those tools. I think one doesn't fit at all in that case.
So I feel the need for speed. Wow, is that right? I feel the need to change the conversation once again. We're more than an hour in here, so let's change some gears. the next topic, very controversial, I'm sure, is new blood versus old dogs. And what we're going to do now is pull in two of the latter. Yes, you heard right, two old dogs. Kim Pomeroy, you've been on, we haven't let you off the hook yet. You're coming back. And Marina Beccaria, another old dog, but really lovely, and it doesn't show, but you have so much to share. So please switch on your camera. Thomas, if you can put back Marina and Kim. And we specifically want to talk about really what the differences are between these two generations. And you each can decide where every panel member falls, but we all have seen that there are quite a lot of cultural differences and differences in the way of thinking and doing things between people that have been doing it for years and years and years and the new people coming in, positive and negative on both sides. So Marina, welcome.
Welcome.
Switch on your mic for us.
Yeah, Marina, she didn't say that I looked good, only you did. That you aren't aging.
You look a little like Colonel Sanders.
Free chicken. Mention my name.
Is that the three-legged chicken that Huey lost earlier?
Yeah, that's why him and I are friends, I think, because he's just my research, right?
So Marina, if you could comment on what are the biggest differences you see in the way of thinking and doing things between the older and the younger generation?
Oh, that's a loaded question. It's
well, if I could interject a little bit and just point out that Marina is very instrumental in kind of bringing along a lot of the younger generation, preparing them for the exams for the AAB or ABB, and has really been a mentor to a lot of people. I employ some of them. So, you know, just kind of to set the stage for people who maybe don't know who you are.
You're very qualified. You earned your wings.
Very much so.
Thank you. Well, I mean, the differences are clearly there. It's very interesting actually with bringing new people to the lab, like new college graduates. I noticed that they oftentimes they have a better manual dexterity than we do, just right away, like off the bat. And I actually attribute this to video games. So to get us all started on that. But so in that sense, they oftentimes are easy to train, like everything that has to do with computers, you know, instrumentation, even time lapse, you know, just things go very, very fast with them. The other interesting difference is that, you know, many of the new people, they never made media in their life. So if there is any you know, situation when you have to change the concentrations based on the protocol that comes from the embryos that come from another program, then this is just, you know, this can be a issue that actually requires some of the old dogs to come in and start barking. So that's when I come in for that. But yeah, it's different. One interesting thing is that I think, and I actually support this wholeheartedly, that the new generation is actually putting more importance into life-work balance, which is not necessarily the case in our history, because I mean, my generation definitely remembers like very long days and working like many weekends in a row and basically not having life as an embryologist. And I don't think it's a good thing. And the more and more research comes in telling us that the stress is just as bad for us as eating McDonald's every day. So we should not be exposing ourselves or our youngsters to that. And so that I actually really like that. So, and I'm learning from my youngsters that way, that, you know, life and work balance is very, very important. But I think there is place for old dogs and young puppies, as long as the culture at work is, you know, conducive of professional and basically human environment. That's all I have to say for now.
Kim, you want to bark back?
Yeah, I just want to say hi to Marina. Hi. Anyway, I think one of the biggest differences in the beginning, a lot of us came from animal science field, and a lot of us came from an area where we had worked with tens of thousands of mouse embryos or cow embryos or sheep embryos, and even some of the horsey people even got into this field. I think that's the biggest. I don't think I don't like to sort people in two groups as far as the negative things that they do, because that never covers one whole group. You're kind of biasing that group. I think both groups do very well. Maybe the one thing I can say is the older dogs tend to have more years of life than the younger ones. I think that's the biggest thing. And because of that, they have a little more experience. So they're a little bit more able to problem solve. But that doesn't mean the younger people aren't going to get there when they're 1,000,000 years old like we are. I'm not talking to you, Sheela. Sheila's one of the young ones.
So taking this a little bit, like kind of building on it a little bit, what about techniques? So one of the things I've noticed in my lab, and I think actually you'd mentioned this at one point in the conversation, Kim, you know, everyone kind of has an inherent way of doing something. You're given a task and you sort of make it your way of doing it. So when you're training young people or bringing them into your lab, do you force them to do things your way? Do you ask them to do things your way and then give them a little bit of slack? Where do you draw the line, and how do you make that judgment call?
A lot of it depends on what technique you're talking about. Sometimes they have to do it my way. That's just the way it is. The worst thing that happened to me is, for a while, I had one embryologist that kept on doing all the collections of eggs from the retrievals in an organ well dish. And I do not like that. There are reasons I don't like it. And I've measured temperature of those dishes to show why those shouldn't be used. So those are things. But if they want to ICSI the best way with a mouth pipette, that's fine. Or if I'm being facetious here, or if they want to use.
Or old dog, really old.
Yeah. Or if they want to use a driver, that's fine. I don't think they have to do it my way, especially if they've worked somewhere for a while. Sometimes it's best to let them do it their way, as long as there aren't any differences in outcomes. And so you have to watch that. Otherwise, if they're a new embryologist, I want to teach them exactly my way.
I think part of that too is earning trust. You know, if you're showing them and you have 20 years of experience and they get to know you and trust you, and you say, I do it this way because, you know, it's more stable or something like that, you know, they might be more apt to give your way a shot versus just dictating them, this is the way it has to be. You can say, these are the mistakes I've made. These are the things I've seen that have gone wrong with doing it other ways.
Exactly. I wanted to say exactly what you said, Ashley. I think it's very important to distinguish between, I think the old school was a little too old that way, that when you step into the lab, you have to forget everything you knew before, even if you had experience, and then start doing things exactly the way that lab was doing. And the explanation often was that, oh, this is because we always did it like that. And I don't think it's a good answer. I think we need to explain to people the difference between things that have a potential of screwing things up, and that's why you have to do it the way we do it, and everybody does it, and you should be able to take over exactly the same way for anybody. But there are other things, like Kim said, like, you know, if that there is a small difference in the technique that works for that particular person, then sure, go for it.
Yeah, here's an example of something where, being an old dog, I thought I knew it all. And I had a new embryologist. His name's Dojun, for any of you that know him. And he was going to do ICSIs. And I was watching him to pass him off on his ICSIs, and he's doing his ICSIs and everything. Afterwards, I said, Dojun, you're just too gentle on these. I'm not sure you even got through the membrane on many of those. Boy, was I wrong. When I saw his results, they surpassed me by far. He had higher fertilization rates. He had better embryo quality. And to me, those are the two things that tell you how well your ICSI is doing, of course, pregnancy rate. So sometimes people are going to come in with a new way of doing something that's going to surpass you. You should change and meet them.
Absolutely. I agree. I think we've all had those moments where we've entered another laboratory for whatever reason and have seen other techniques or people doing things that we've done we haven't thought twice about, with a subtle difference. And those subtle differences sometimes are impacting at the end of the day. So we need to keep an open mind as well, I think, with respect to what we see and how we practice what we do.
So I'll just add on this one. I was trying to do the aspiration where you aspirate a lemma, and I believe that it might harm the oocyte. So I just drop my spermicide. I don't do any aspiration at all. And my embryo development, there's a big difference, because I believe that you want to conserve the cytoskeleton side. And so, yeah, that's things that we learn as changes are okay as long as you have a best outcome, as Kim said.
I almost want to call on Peter Nash now about the cytoplasmic mixing. I see his name there, but I don't know if he'll be willing to make an appearance. But just in case he doesn't, I'm going to throw out a question from the audience here. I know I'm not going to say it right. Guidre Bello Lopez, since we were talking about mouth pipetting, is asking, do you think mouth pipetting is still acceptable? I've seen some on social media, human IVF lab, why? Huey, you've been quiet.
I'll say yes.
Mouth pipetting, I think,
Absolutely.
is terrible. When I got into IVF, I saw that. I just learned from the Jones Institute. They just taught me how to do ICSI, and I was so excited to do it. And then I went to visit a lab, and I saw them do it, and I was just I'll be honest, I was shocked that someone did that. And so I'm against mouth pipetting. But I like to, back to what everyone was saying. It's nice to see how everyone's willing to make changes and allowing new embryologists to do certain things that are different than old ways, because I think that's how our profession has progressed, and I hope it continues to progress. My concern is that new embryologists are being, I guess, fenced in as clinics are being more centralized, and I'm concerned about that. So, but I'm happy to see the panelists are very supportive of the new embryologists making changes.
I think we should add to yours.
To the European development of embryologists? I mean, what's the pipeline of people into the field in Europe? Obviously, we're talking about the US experience here, but on an international level, what are you dealing with and what do you see?
I think, specifically in Greece, we're very lucky because I think we have quite a few MSc programs that people finish their basic degree, like their BSc, and then they embark on one of the MSc programs. And for example, on just basic biology of reproduction, or it could be something more specific and more, apt on assisted reproductive technology. But then after they finish their MSc, then they start looking for jobs, and then they start thinking what's the best way to become an embryologist. I think that's one of the biggest problems. That's one of the most difficult questions I always have to answer to my students. How do you become an embryologist? How do you become an embryologist? I don't know. You finish your BSc or an equivalent, basic degree in science, and then you do a master's, and then what? And then basically, you join a lab, and you're lucky enough for people to train you, and that's how it happens. But that step is actually very vague. In Greece, we're lucky because we have a good standard of master program. So the students, the people that we get in to train are actually at a very good level. I mean, their knowledge and their skills even, they're at a very good level. So we don't have any issue of flow. In fact, we have overflow of biologists that want to become clinical embryologists, and that is one of the issues. in Greece and in Europe in general, it's really difficult to find training positions for these kids. It's really hard, and they're very driven. They want to become clinical embryologists. I mean, the students that I'm dealing with, because obviously at the university I'm in physiology of reproduction, so the students that will come and work with me are students that want to become clinical embryologists ultimately. So how do you answer that question? I really don't know, but we're very lucky with regards to we have overflow of clinical embryologists, but at the same time it's really, really hard because it's hard for these kids out there. Becoming clinical embryologists is really, and that's one of the first things that I tell them, it's really hard, and sometimes it's a matter of just being lucky and be at the right place at the right time. With regards to training them, one of the things that I have really enjoyed throughout these years is being able to visit different labs. And every time I walk into a different lab, I'm just a fly on the wall. Can't be a fly because it's a good lab, but generally, you need to be quiet and you need to just watch and see what they do and just learn. And every single time there's something to learn. It's unbelievable because everyone's got their own signature, their style of doing things, and I think that's amazing. So with regards to training, I think we're trying in our laboratory, we're trying to show them and discuss with them the different options, and then we explain to them why we do it that way and why we think this is the best way. As Kim said, if they're young and they haven't been trained elsewhere, I would like to try to train them my way, but I'm always open to see how they want to do things, and if there's something that works better for them. I will not try and push them and break them so that they can do it my way. But anyway, yeah, one of the main things is how to become a clinical embryologist. There is a gap there. It's not an easy question to answer.
Thank you so much, Maura. I have to interject and welcome to the stage the ultimate guest appearance surprise, Dr. Peter Nage. It's great to see you. I know it's Nage, I read it, sorry. Yeah, thanks for appearing. I called you in first because there was the comment about cytoplasmic mixing, but you also have trained so many people. You're also from Europe, so if you could address a few of those issues for us, start with the cytoplasmic mixing. Are you still doing that?
Not at all. Never really done. So, I don't think it has been a good idea or it has been practically worked out very well. So that's not something that I would promote in the past or in the present. Regarding the mouse pipette used for ICSI, I started to do ICSI in '92, which is a long time ago. At the VUB, where Dr. Palermo was working with Van Stertegem and the group. And when I moved to RBA, that was in 2002, so 10 years later, I have been always working with the regular injector and not with the mouse pipette. But when I came to RBA, I saw that my colleagues here, they were all using mouse pipette. And, I was surprised, but I did try it. And actually, I realized that mouse pipetting gives a much better control than the injector. So I switched, and that just goes to the point of Mara. But you just thought that you have to be open-minded. Whenever you go around in the world, any laboratory you visit, you can always learn something. And I just also can tell you that from own experience, using mouse pipetting for ICSI and also actually for embryo biopsy, it gives much greater control. So, you take it. Thank you so much, Liesl, for inviting. If you don't mind, I would just disappear again, okay?
Okay, I'm just but thank you so much. We really appreciate it.
Thank
I
you.
did get a message from Giles that we 10 minutes.
Yeah.
Very,
So we're getting pretty close on the end. One question that keeps popping up, a few questions like how do you get into embryology, or how do you make the transition in embryology? But the one that seems most common is how long do you think it takes to become a clinical embryologist? So to kind of distill that, let's just say average middle of the road, competent embryologist, not a junior, not a senior, just an everyday working embryologist. Go around the room and just kind of, what do you guys think? Based on your experience, without the proteges and so on that we tend to see. What do you think is a reasonable timeline?
I think years. You know, it's not just a function of learning the skill, but you know, learning what to do when things don't go well, and those opportunities don't present themselves every day. At least, hopefully, they don't. So, you know, you might become proficient at a specific task, but how to troubleshoot that task when a device fails, or you find yourself in a sticky situation. Those are the skill sets I think that really differentiate a solid embryologist from you know, someone that's still in the training phase. So my take would be years.
How many years?
I agree with Bryan. I've only trained one embryologist, and it was about 2 years into I felt she was very comfortable being on her own to brainstorm. And I would sneak in the lab when she's going to the bathroom before she's doing ICSI and like kind of screw up the injectors, kind of see if she would correct them. She didn't know that time, but I think because of that, she became one of the best embryologists at Boston IVF at that time. So I was really proud of her and still proud of her. So, but I agree with Bryan. It takes a couple years, several years to really get an embryologist to be able to brainstorm when things go wrong.
And
I think it depends on lab size too. I think, you know, if you're in a really busy lab, maybe a year, but 1 to 3 years, depending on how busy the lab is.
That's true, you know, but I feel like even the busier labs have shortcomings because they're so busy. Now training becomes almost impossible. So being in a busier lab, you sometimes get less exposure than if you just have one embryologist training another embryologist. Then there's a lot more exposure, one procedure at a time, and you're probably in a more ideal situation. So in a lab where we do, we're fairly busy, I'd like to say, and it takes a good 2 years for an embryologist to be comfortable on their own and feel that they can probably get through the lab work without having to go get help. They're still not proficient on all of the procedures, but they're competent enough where they're comfortable in making decisions. They can triage, and then they can brainstorm and make the appropriate calls when needed.
And I would just add one more thing for the type of equipment that the lab specific has. If it's like multi type of incubators, time lapse, different type of media. If you're doing vitrification, we're doing slow thaw. I mean, there's some embryologists that have never done a slow thaw. That when they arrive embryos from other clinics, I was like, oh, I never seen this type of straw before. So those things are, you see nowadays that slow freeze once a month or even less, depending if you're not receiving embryos from outside clinics. So yeah, equipment, 2 years, I think it's appropriate, but you're not fully competent yet based on where you're doing your training.
Michael, you haven't chimed in yet.
I'm in the 2 to 3 year range as well. I can say my first 2 years were a real challenge, but I was in a batching laboratory where I only could do a few retrievals one week out of the month. And then you go 3 weeks without touching a procedure. Any task is difficult to learn that way. So I did move my entire family halfway across the country in order to join a lab where I could do retrievals every year every day until I mastered them. And once I reached a good training laboratory, I just hit the ground running and haven't looked back since. But even at nice accelerated pace, it still took me 2 to 3 years to feel confident in what I was doing in the laboratory.
Betsy, so you don't train embryologists, obviously, but you've certainly transitioned several people from your lab into the embryology world. I've met a couple of them over the years. What's been your experience, or what are your thoughts?
So I do see a different perspective, because when they come into my lab, they're working specifically in andrology, although we are handling frozen shipments that come in from other centers for long-term storage. I think one of the biggest things that the takeaway that I get from the students that I see is that they're only interested in embryology, and that there's a hierarchy, that embryology is the queen and the king of all of the reproductive biology, and andrology is just sort of the forgotten sibling, you know, that is like, it's kind of interesting, but not really, and it's very boring to them. And I find that typical. I'm not insulted by it. I find it disheartening. And then what I hear later is that a lot of these people leave embryology after about 2 years, or even so, because the burnout is high, they can't take the anxiety, and they're not the right fit. And we try to explain that to them when they're here, is that you're handling human DNA. You need to have a pretty thick skin, and it can be pretty intense. And so I feel like we're sort of the psychological training ground for launching embryologists into the field. I would like to see more andrologists, of course, because then trying to just find somebody for us, the learning curve is about 1 year to 1.5 years, depending, because every sample is different, and there are a lot of things that we can fix that they don't have in their arsenal because they're young, or not even young, just inexperienced.
Okay, so we're at about time now. So thank you to all of you. Would you all like to say kind of a parting word to our audience here? Thoughts, advice, just kind of a final takeaway? Huey?
I thank you, Gerry and Liesl, for this awesome webinar, and thank you, Gerry, for really starting Maverick. I think, as any new embryologist, new and old, we love it because it's, for me, it makes, even though I'm in a little more in industry now, it makes me feel like I'm not the only weirdo that looks at sperm or procedures and stuff like that. But it's not about just looking for weird things. It's about, getting great data. For new embryologists, it's learning from these amazing embryologists that have been out for 10, 20 years. And I think that's what Maverick represents. And I'm really thankful for it and to be a part of it. Thank you.
Mara? I'm going back.
I'm new to the Mavericks, as you know, relatively, and I just a huge thank you. And the Mavericks came into my professional life at a time that I really needed it, as you very well remember, Gerry, because we were trying to finish up a project and just distribute questionnaires, and it was just so hard. And then just Gerry came along, and he just made that easier, and we managed to publish that paper and just help my students finish their thesis, which was really grand for me. So fantastic for Maverick. My message to everyone out there is just communication. It's the basis, the ground for everything. We need to talk to each other and, just check in with each other and just be alive and kicking.
Thank you. Bryan?
Yeah, I think it's a fantastic group and in a really an approachable forum. And I think we're lucky to have such a large representation of talented and diverse people amongst us. And it's nice knowing that when we have questions, there's people willing and capable of answering them and helping guide us in the right direction. So thank you all very much.
Sheela?
Well, for one, this platform that we have is amazing. It's remarkable. Thank you to everyone in the industry that has contributed to such platforms and gotten our word out to the audience. And the audience, thank you for joining. This is phenomenal. I didn't have this when I was learning embryology, and certainly would have been beneficial. The amount of knowledge that is being shared in an hour and a half, you couldn't get that amount of knowledge in a classroom setting or in just, one study period anywhere in the past. So I find that it's a privilege in our time, and our new embryologists that are coming in that are training. The message that I have for you guys is just hang on tight. We have seen our days and we see yours, and we're open to learning from you and hope that you give us that chance. And we're trying constantly to become better at what we do and to improve the overall outcome. So sometimes it just takes years of exposure before you can learn why we do the things that we do and why we're so set in our ways, because we've been around the block more than once. And so I'm sure Kim would disagree with me, but we're learning with you. So thank you again for having me.
Thank you. Betsy?
I just ditto what everybody is saying. And I think it's important for us who've been in the field a long time, and we were talking about old dogs and new dogs, is that we have to keep in mind that sometimes there is a very extreme difference between style and protocol. And we have to respect that if our tech is following protocol, but their style isn't ours, we just have to respect that, because there is a difference. And I try to delineate that out, and I hope you know, we can all be patient with each other, but I love being part of this Mavs. I've learned a lot. It's a very safe group, and I really respect how everybody is so respectful. It's just really, it's impressive. It really is. You don't see it a lot.
Ashley?
I also want to thank you guys. I think one of the strongest tools in your box is your phone a friend option. I tell a lot of students that. And for the current, staffing issues that everybody is having, traveling to meetings and the ability to connect in a really non-judgmental forum is important. And I think Mavericks allows humor, and it allows for asking that question, sort of putting yourself out there in a judgment-free zone to people who really care, are invested in the field, in the patients, and in the science, which is really, again, I think important. So yeah, thanks for the opportunity to participate, and count me in as a phone a friend on Mavericks if you need it.
Thank you. Salu?
I'm muted. Well, thank you to the audience for being here today and participating of this forum. I think it's as a person that started and had wonderful mentors from Maverick and introduced by my former mentors. I think this forum allows us to be sharing knowledge in science that it's not detrimental, like Ashley was saying. And it's a great opportunity to learn more, especially for new embryologists like myself. Not really, but that's how I feel. I feel like a young puppy amongst all of you. So thank you.
Michael?
Well, I say we are very secluded in the laboratory. We don't, especially the new generation coming in, you may know 1, 2, 3 senior embryologists, but it's groups like Mavericks that really connect us and open our eyes to the greater world out there. And it's groups like Mavericks that have given me the confidence to try things maybe a little bit differently, or even explore crazy ideas and get feedback from what people with a lot more experience have seen throughout the years. But then if COVID has done one good thing in this world, it's the development of platforms like i3 to connect everybody, and again, get us talking so that we can become it's just really accelerating the pace of improvement in our laboratories, being able to communicate and learn from each other's successes and failures. So thank you for everybody for being open and honest and sharing those with the next generation and soon the generation after that.
We'll turn this over now to Liesl to sing us out here. Go ahead,
Well, thanks again to all the panelists. I'm not going to name all of you again because we just went through that. But in addition to our guest appearances by Kim Pomeroy and Marina Vakaria, thank you so much. And of course, our oldest dog, Peter Nosh, for making a surprise appearance. We really appreciate it. And then thank you very much to i3 for allowing us to occupy this airspace today, especially the organizing committee, Jacques Cohen, Peter Nosh, Giles Palmer, Thomas Elliott, Mary Ann Savetes, and Shai Sissedruden. The next session is next week, same time, same place, and it will be on lab management again, but this time it will be about safe storing of embryos and gametes, being proactive in the face of cryo-dure disasters, and the legal issues around it. Now, last but not least, if you are not a member of Mavs at this point, you too can become one of the elite, just by making friends with those on the inside, and by the ways of appropriate bribes and contributions, of course. And email us, we'll let you know what might work. But soon you may too find yourself one of the lucky ones to be admitted. Until then, soar high, everyone. Gerry, you can be my wingman anytime.
Bullshit. You can be my wingman. See y'all later.